Thank you, Mohammed. Excellent. Okay, right. Let us proceed. So I'm going to we're going to give an update on management of cardiogenic shock in the middle of 2024. Start with this data from last year. Talk about care management. Let you know the overview. How's that? Okay, and you're muted. Yeah, so we're now got a feedback loop. Okay. Sounds better now. Okay, good. Right. Oh, maybe I should move my speaker view, shouldn't I? So I'm not in the middle of the slides. So the patient in question was 67 with no previous medical history, no previous hospital admissions, certainly no cardiac conditions. He presented to the ambulance service reporting 90 minutes of chest tightness, sweating and breathlessness. When they assessed him on arrival, he was withdrawn and agitated. He was peripherally shut down. They were unable to palpate either radial pulse. His ECG showed a very broad right bundle branch block with ST elevation in the high lateral leads and also in the anterior leads. And the ECG was telemetered to coronary care, and he came straight to the cath lab around about midnight on a Saturday night. I'll talk you through the angiograms. This is the first picture of the left coronary artery, and there's a major missing branch. You can see that the left main stem, just at the tip of the catheter here, is narrow. There's a very unusual appearance here, and then there's a branching circumflex. The right coronary artery is healthy, but there's no collaterals to the left coronary artery. He was very unwell, peripherally very cold, hypotensive. We put in an intra-aortic balloon pump, which was the only mechanical support that we had available. We supported him with boluses of inotropes and proceeded to angioplasty. You can see a little bit more in this view. This is a guide catheter with a larger caliber, allowing us to perform PCI. You can see the left main stem here is abnormal. You can see a very odd appearance here, which is a dilated coronary aneurysm that's full of thrombus. You can see a thrombus getting into the circumflex, and you can see a little bit of flow in the left anterior descending beginning to come back. This case had every sort of technical challenge that would be interesting on a patient who was stable and coming in for an elective angioplasty. But when somebody is critically unwell, and it's extremely difficult to get the wires to get into the major branches, that's unpleasant. That's very time critical that success proceeds, and it's very difficult to make progress. You can see here that while there's a little bit of flow coming back in the left anterior descending, which is at the top of the screen in this view, the flow is now blocked in the circumflex. You can see that the aneurysm presented difficulties, that the balloon wouldn't just track down around the corner until we adjusted the wires by withdrawing. But once we started getting balloons in, we started to make a little bit of progress, and the flow started to improve. Here you can see the circumflex is now open. The LED is still occluded, but with readjusting the wire and more distal inflation, we got slightly better flow back in the LED. This appearance here is the preparation for an intravascular ultrasound. I'll not show you those pictures, but you could imagine that the left main would be absolutely full of thrombus as well as disease. We inflated the critical lesion at the distal left end of the left main stem. We positioned a stent in the left main. You can see that the critical stenosis has improved. The thrombus is all gone. Some of it will have been dissolved by the combination of heparin, tirofiban. Some of it will be macerated by the balloons against the walls of the coronary arteries. Some of it's blocking the distal LAD. We optimized the stent. And at this point, we've made some progress. He's got coronary circulation into the left side of his vessels. It's not perfect, but the longer that we stay and try and achieve a good angiographic result, the greater the insult as a result of the procedure. He remained unwell, hypotensive, requiring support, and was admitted initially to coronary care. I'll let Euan tell us about the management of cardiogenic shock and patients who are in this these severe consequences of acute myocardial infarction.
Thanks, John. So very quickly on cardiogenic shock, just as a background to it, makes up approximately 3% of critical care admissions. In 2023, we had 7 patients that came into intensive care in Ninewells. Half of them stayed with us, half of them went on to specialist services from us. About half of the presentations are ischemic in nature, mostly from STEMIs, as in this case. But 50% of them are non-ischemic in nature as well. The mortality, unfortunately, remains fairly high. About 50% of patients with cardiogenic shock with signs of hyperperfusion will die in hospital on that admission. And there's not really been a huge amount of improvement on that in the last 20 years, despite advances in mechanical cardiac support. We've not really seen a great improvement in the hospital mortality. And the prevalence overall is increasing slowly. What do we want to do with them? So we want to maximise the patients that survive this episode. So either temporising them until their heart function can recover, as they can do in the first few days following an ischemic insult, or until they can get a definitive treatment like transplant, if that's an option for the patients. As well as making sure we maximise the group that survive, it's important that we reduce secondary organ damage in those that do survive, so they've got as good a functional outcome as they can possibly have. So minimising the time these patients spend in a shocked state to reduce the impact on their ongoing life should they survive. Early recognition of those that are going to benefit from advanced mechanical cardiac support and providing stabilisation and transfer for them. And also recognising those that actually we can't fix. The treatments for this tend to be fairly invasive, tend to be fairly unpleasant. And when there is no possibility of improving their outcome, then we shouldn't be burdening patients with these options. How do we progress? There we go. The Society of Cardiological Angiography and Intervention came up with a nice way of categorising shock. A couple of years ago, they formalised this into a sort of A to E. The sort of classical patients we think of having cardiogenic shock being in this class C, where they're hypotensive, tachycardic, with signs of end organ hyperperfusion. That's not the only patients that present with cardiogenic shock. Patients that are in the earlier stages are at risk of getting to that stage, and if we can stop them advancing from the early stages to a more profound stage, then we can potentially improve outcome. So it is a spectrum rather than simply a disease state in and of itself. That balances nicely with the next slide, which looks at the way we classically look at managing these patients, and so traditionally go from a sort of basis up, so working with basic measures, to pharmacology support, so drugs, mechanical support and balloon pumps, advanced mechanical support, ECMO, and up to transplant. We probably need to modify how we think about that at times, and rather than working from the base up, actually sometimes before patients deteriorate, having a further look up the tree rather than waiting for them to deteriorate before we advance up, and that's what we'll get onto later on. And in terms of the drug as option, we've got really in Ninewells we have sort of 4 main vasoactive options. None of them are perfect. So noradrenaline and adrenaline we're all familiar with. Dobutamine maybe slightly less so outside CCU and ICU, and oxymone is probably one that isn't used much outside intensive care. Physiological sense would suggest these patients need inotropy rather than vasopressor. but the evidence base doesn't really support this particularly well. In fact, the few trials that exist on this suggest that actually patients on larger doses of inotropes do worse rather than do better. The rationale probably behind this is that shock state leads to hyperperfusion, leads to release of inflammatory mediators that cause vasodilatation, and you end up in a sort of mixed shock state fairly rapidly. Yes, in their early stages, these patients are very vasoconstricted as a way of compensating, but that tends not to last too long. The evidence base around all these drugs are really tenuous, and actually the American Society of Cardiology had a really nice line in one of their more recent guidelines that suggested that familiarity with drugs was probably as important as the agent you picked itself. So having an agent that your medical and nursing staff are familiar with utilizing in the most efficient and effective way possible is much more important than the actual drug you pick. But there are other ways we can pick drugs, which I'll come on to in a wee second. In terms of fluid, you're classically overloaded. So stage C, patient on that category has pulmonary edema, they raise GVP. They're classically overloaded when you think of cardiogenic shock. What they need is aggressive diuresis, either with loop diuretics or if their kidneys are failing on us, renal replacement therapy. But not all patients are in that state. Some patients are getting into that vasodilated, leaky capillary, intravascularly dry stage and actually do need some fluid stabilization. What's important with these patients is that we aren't throwing litres and litres of fluid blindly at them, but we're giving them small aliquots of fluid challenges, assessing a response, and if they're not responding, not continuing to give them fluid and overloading them. But these patients do need fluid, and I think that's something we're beginning to recognise, that not all cardiogenic shocks are dry and need dried out hard. How do we pick the right thing? How do we get our fluids right? How do we get our drugs right? Clinical assessment and standard monitoring is the cornerstone of any sick patient. But we have a few toys that we like to play with to try and give us a bit more information in addition to our clinical assessment. It's very much an integrative approach rather than hinging decision-making on drugs or fluids based on single numbers and values, but integrating the whole data set together to give us the best option. Cardiac output monitoring is an area of a bit of controversy. Pulmonary artery catheters do provide, without a shadow of a doubt, the best numbers, the most accurate and reliable numbers, but they've kind of disappeared out of intensive care since the early 2000s, and now you only really find them in cardiac units. What we do have is this device we've got on the right, which is called the MostCare, which is Vigon's pulse contour analysis device. It works on an arterial line, so it presents no more risk to the patient than the arterial line they'll already have if they're in an ICU, and gives us fairly reliable and utilisable numbers on cardiac output, systemic vascular resistance, and a bit of an idea of where we are in terms of preload, and allows us to titrate our drugs in a little bit more nuanced fashion. Bedside echo is becoming far more common in intensive care now than it was even 10 years ago. We're getting increasingly comfortable utilising it to guide our treatment of inotropes, so repeated assessments, looking at changes in cardiac output directly using echo has a place and is definitely an expanding thing within intensive care. So integrating all those together to allow us to pick, does this patient need inotropy? Do they need vasopressing? Do they need a bit of fluid? John mentioned this patient ended up with a balloon pump straight from the lab. These are mechanical cardiac support devices, the only ones we have available currently. And Tayside, they're percutaneously inserted normally into the femoral artery, sit in the descending aorta, and have a balloon that inflates and diastole, pushing blood down the aorta, reducing afterload and the work the heart's having to do, but also pushing blood back against the closed aortic valve, which will push blood into the coronary arteries and in theory improve coronary perfusion and oxygen delivery. They make a lot of physiological sense. The evidence base for them is somewhat debated and somewhat tenuous, but I think they do make a difference to some patients, and they do give us a bit of stability in the sicker patients that we wouldn't have otherwise. When we run out of options, we speak to our friends at the snappily named Scottish National Acute Heart Failure Service, or SNAFs. They clearly didn't read the memo that all acronyms must be snappily named, because that's a bit of a mouthful. They're based at the Golden Jubilee in Clydebank and are a specialist group of cardiologists with close support from cardiac intensivists, anaesthetists, and transplant surgeons, as well as a greater MDT that are involved in the workup of patients for transplant and mechanical cardiac support. Their benefit is that they cohort experience, so they bring together the sickest group of cardiogenic shock patients in the country, and they look after them in a bigger number than any one centre in Scotland could manage. And I think there's fairly good evidence coming out from a lot of other specialist things that the more you do of them, the better you'll be at them. So there probably is a benefit to the patients being there, regardless of what's happening to them for some of these patients. They also provide advanced mechanical cardiac support, so ECMO and VADs, which we'll talk about very briefly in a second, and they're the transplant centre for Scotland. The biggest problem with the Jubilee is where it is. We're talking about patients that are deteriorating to the point of we have nothing further we can offer them locally. They're still deteriorating, they need further management, and they're 86 miles away from us. So transferring these patients in the back of an ambulance is going to take you about an hour and a half, 2 hours, which is a very, very unpleasant ambulance drive, I can assure you, having done it a few times. These patients deteriorate in transfer, they always do. And it's a big risk to the patient. And this is probably the biggest problem that can present us with these patients, is actually getting them to the Jubilee. And there are patients where we've had to turn and say, actually, we can't move this patient at the moment. We just can't do it without causing a sort of insurmountable risk of them dying in the back of that ambulance. Briefly on ECMO, just because it's interesting more than anything. When we're talking about ECMO for cardiogenic shock, we're talking about veno-arterial ECMO, so a line from the vein pulling out most of your cardiac output, and an arterial line plumbed into your femoral artery, pushing it back in again. They're modified cardiac bypass circuits that provide a pump, provide pressure and gas exchange. They involve big cannula, so up to about 25 French, so the size of a fairly sizable chest drain, that goes into femoral artery and femoral vein. It's got big complications with it. So limb ischemia happens about 5%, significant GI hemorrhage requiring significant transfusion in 3%, and intracranial events, either strokes from the prothrombotic nature of these circuits, or bleeding events from the massive amount of anticoagulation these patients require, at about 4%. So it's not without its risks, and although it is a life-saving treatment, potentially it has a huge burden of morbidity associated with it, and those that survive. There was a recent New England Journal trial called ECLS Shock that showed no real benefit in using it early over standard management of these patients. I don't think that's the end of ECMO. I think there's definitely patients that benefit from it in terms of bridging them to transplant that wouldn't have survived otherwise. But certainly using it as an early rescue, its risks are just far too great for that to be of any benefit. And then the sort of end of the line result for some of these patients that are in a good enough pre-morbid state to get there is transplant. The numbers are going up every year. 185 transplants in the UK in 2023, of which 40 were in Glasgow, which was the busiest of all the transplant centres in the UK. 80% of those transplants are done in what are described as urgent or super urgent cases. Urgent cases are patients relying on IV infusions to maintain perfusion. Super urgent is patients on mechanical cardiac support. So very sick patients that are being done, and their survival is really quite good. So 92% at 30 days, drifting down to 71 at 5 years, but certainly compared to the 50% in hospital mortality of cardiogenic shock, a big improvement on that.
I'll update you on our patient. He spent about 24 hours in coronary care on a combination of intra-aortic balloon pump support and noradrenaline infusions. His lactate did reduce. He was oliguric, and his creatinine rose. And after some discussions, he was transferred initially through to intensive care. In the face of escalating support, he was discussed with Glasgow on the Monday morning. He is 67, and the convention has been that the cutoff of 65 years is absolute for advanced support. and that's still what they say on the website. But they did take him on. He was treated initially with ECMO, and then left ventricular venting, because ECMO doesn't empty the left ventricular cavity. Pressure builds up and can lead to worsening pulmonary edema. He had surgical implantation of left ventricular assist device. But despite all of this support, approximately 2 weeks after he presented, he still had intractable pulmonary edema, and he was palliated. So, Euan, how are we going to do things better?
So, as I said at the start, the outcomes from cardiogenic shock in general are fairly grim. And if they're deteriorating, certainly most of the 50% mortality comes from the group C that we were talking about earlier, the sort of classical presenting patient with hyperperfusion. How can we make things better? Well, the best way to do that is stop patients getting to that point. So identifying patients that are at risk as early as we can, intervening before they get to that point of being hyperperfused, having that inflammatory mediator cascade and vasodilatation that occurs, recognizing them and acting early when they do show signs of deterioration, not waiting until we're in a situation that they're absolutely needing to come to intensive care when we start actually doing those things. Standardizing management as much as we can. Because of the lack of evidence of some of this, there is variation in practice. Variation in practice, while sometimes really good, can also lead to people being unfamiliar with what we're doing in terms of the nursing staff supporting decision making, not being familiar with what we're doing. So standardizing things as much as we can, and hopefully improving our outcomes a little bit. How are we going to do that? So this is introducing the concept of the shock team. This is very much not our idea. It's been done in numerous places around the world. John's been in touch with teams from Bristol that have had fairly good success in improving their outcomes. So it's very much not an original 9 Miles idea, but it's something that's been shown to make benefits elsewhere. Recognising patients are at risk right from the start. So most of these patients will feed in as an ischemic driver through the cath lab, but we can feed other patients into the pathways at other points. But recognising these patients at the time they present and that they're at risk of developing this right from the start. Early interventions when they are at risk, so before they deteriorate, and early multidisciplinary consultant-led decision-making on how we're going to manage this patient, where we're going to manage this patient, what are our immediate management goals, what are our triggers for re-reviewing and for escalation of that, and early decisions on escalation, both within the hospital in terms of are they going to CCU, are they going to intensive care, are they actually not going to either of those because they're not suitable, but also are we going to speak early to the teams in Glasgow and consider transferring this patient before they become too unstable to move.
I think we did most of these things for the patient in the case I presented. I think even in retrospect, it's hard to see that what we actually did in Dundee would have been different with a discussions, but we may have just done everything slightly sooner. We may have been able to transfer them sooner. We might have had earlier conversations with Glasgow, and in difficult cases where we've made a lot of progress and we've done a lot of support, we're always wondering whether you knit it together in a slightly different pattern, and it might have pulled through. For this gentleman, I'm not sure. To give Bristol full credit, I'll show you some of the. I'll briefly show you some of what they've done and the results. This is an example of the benefits of staying late at meetings and chewing the fat with colleagues, and they then say, well, they invite you to other meetings where they present their data. So they've integrated a system so that patients who are at very high risk, even identified by the paramedics, will go through a process flagged up and be reviewed by the cardiogenic shock team as soon as they get to the lab. We've copied these indices of high risk whilst in the cath lab for our current the current draft of our development, and all of these will potentially identify patients at high risk benefiting from increased support. This is not something they're not doing. The benefits from their approach has not been in terms of adding mechanical support. It is very much the simple things. So identifying somebody going into coronary care as a high risk bundle, not relying on generic scoring systems, but measuring the urine and timed reviews with planned escalations. Again, consultant discussions about somebody who's not rapidly making progress in coronary care and may benefit from early intensive care. So they presented some preliminary results. They've been doing this for about a year. They have about 10 shock team activations per month, which would translate to about 6, comparing our primary PCI numbers. They've taken a sample and they've done their best to match controls, which is obviously not the same as a randomized comparison. There's clearly residual bias between the groups, but they were able to show a reduction in in-hospital mortality in relatively similar patients from 42% to 13%. Now that's clearly too good to be true, but it's also too good not to try and copy. This came at a cost of a slightly increased ICU length of stay, but in that ICU stay there was less requirement for ventilation, less requirement for inotropic support, and they halved the cardiac arrest rate. So clearly they are able to identify high-risk patients and manage them well. And we would like to try and, well, first of all, emulate that approach and potentially gain a common data set and collaborate with them, because when somebody's doing the right thing, you want to copy it. And then I'm just going to briefly review the data and what we did, and just a little bit more perspective, perhaps from the cardiac point of view. This was the previous positive trial in cardiogenic shock, and you'll see the date on that, 1999. The shock trial was 302 patients who were randomized to early revascularization for STEMI or initial medical stabilization. They were all on advanced support, so 99% were on inotropes and 86% had balloon pumps, but there was an additional benefit from early revascularization. So this is the 30-day result, which was the primary endpoint of the trial. And while there are more survivors in the early revascularization group than the medical group, that was not statistically significant. However, the difference between the two groups at 6 months and 12 months was statistically significant, and the shock trial was accepted that early revascularization was the treatment of choice for a cardiogenic shock. And perhaps one of the really important things from the shock trial is looking at quality of life in the survivors. So this isn't everybody; it was a subset of the trial. If you look at the bar charts, they're the other way around from the previous graphs. So this group is the initial medical stabilization. This is the revascularization group. The unfilled columns are people who are in class 1 or 2, so that's minimally symptomatic. And the hashed columns are 3 or 4. So when you look at survival at a year, the vast majority of survivors have very good quality of life, and we're not rescuing people to condemn them to severe heart failure. That if we can get them out of the state of cardiogenic shock, then the quality should be good. This is a diagram that I'd like to try and copy at some point, but I've not got the artistic skills. But the concept that cardiogenic shock is a spiral of increasing insult. So what's happening is bad things in the heart, which leads to the consequences for the rest of the body. So you have increased end diastolic pressure from the left ventricle that's failing. You have pulmonary congestion, hypoxemia, which worsens the ischemia. You've decreased cardiac output, hypotension, lowering the coronary perfusion. You have systemic perfusion that's decreased, the compensatory vasoconstriction. All of these things are pushing the patient further and further down the spiral. Euan talked about the systemic inflammatory response that starts. And when a patient has early revascularization, a lot of these things are getting worse because the guide catheter may lead to ischemia because it blocks the or splints the left mainstem. Whenever we blow up a balloon, we cause direct ischemia. We release small bits of clot into the infarcting territories and block off small blood vessels. We're giving people contrast, which can increase their risk of renal dysfunction. So when we take people to the lab in cardiogenic shock, we're potentially pushing them further down that spiral, making it harder to recover. And yes, more people will recover from that, but the procedure here in this American diagram, it's like a DC cartoon. The revascularization is this magic intervention, relief of ischemia and survival, but that's an additional insult to a patient who's already critically unwell. And the landscape, as Euan said, for 20 years has been nothing but depressing. So a randomized trial of patients with intra-aortic balloon support versus inotropes alone. This was a great shock. We thought that intra-aortic balloon pump would be much more effective than that. And in, I think, 600 patients, there was no statistically significant difference and no trend. The guidelines used to tell us that we should revascularize every occluded vessel. And again, not only was there no benefit from complete revascularization, there was a risk of harm from trying to do too much. This one is less counterintuitive than the balloon pump result. That reperfusion of an occluded vessel is generally quick, and though there will be some reperfusion injury, you're generally getting quite a lot of bang for the buck. But you can spend a long time using a lot more contrast if you're trying to treat everything. And so we've certainly changed our approach. So the patient was reperfused, the left main stem was opened up, but I didn't try and make the rest of his coronaries look perfect. The ECMO trial was also negative, and ECMO requires a lot of support. You need specialist technicians to really to run the pump. So that would have created difficulty for us had that been a positive trial. But then April this year, we had another positive study. So the Danger Shock trial published in the New England Journal 2 months ago. Multi-center randomized control trial of patients in cardiogenic shock. Initially, they'd hoped to do it in Denmark, and it was funded by the Danish research body and also by the company. They increased the recruitment to centers in Germany and also to Harefield in London. But it took them 10 years to recruit 360 patients to the trial. The inclusion criteria were what you would expect: adult patients with STEMI, with defined cardiogenic shock, and this is the intervention. So to put in a impeller pump is not difficult. This is a pigtail catheter, which you get to put into the left ventricle on your first day as a cardiology registrar, and you put it out at the apex, and then you thread a guide wire into it, And then over the guide wire, you thread the impeller device, which is a pigtail with lots of holes in the side of it. There's an inlet to the pump here that sits in the left ventricular cavity. You take out the guide wire there. There's a pump here, and that aspirates the blood from the left ventricular cavity and spits it out into the aorta, and that gives you a cardiac output of up to 4 liters with the current device. And patients who are on the device, you may see loss of pulsatility of the pulse trace because their systemic circulation is essentially being delivered by the impeller pump, which allows the ventricle to depressurize, which will then increase the coronary filling pressure, which will then decrease infarct size and then potentially allow recovery. The patients in the trial, I'll just talk you through some of them, but our patient was very typical for the trial, age 67, hypotensive and hypoperfused. The median arterial lactate was a lot lower than his, that had an anterior infarction. Most patients were in the category C. Our patient was probably category D to E when he presented. The onset to randomization was longer in the trial than for our patient. What was definitely different to some of the other trials was that a significant proportion were randomized before they were revascularized. So approximately 50% of the people in the active treatment received were on the impeller pump before angioplasty was attempted. The other half were randomized after the revascularization procedure. They were all treated with, or pretty much all treated with angioplasty. Some had multivessel PCI. The impeller pump was successful. It was quick. Very little device malfunction. It is a reliable device. There was escalation to other forms of support. So patients in the non-impeller arm, 21% had some degree of escalation, and a variety of devices were used. And as you might expect, there was fewer patients required escalation when they'd had the effective support applied earlier. They still required a lot of inotropic support, but death from any cause was reduced significantly from 58% to 43%. The number needed to treat is approximately 8 to save a life. There was a combined endpoint which was also favorable. This came at a cost of significant safety events. So these are big centers that are doing a lot of support, very familiar with wide bore access devices via the femoral artery. But there was severe bleeding in 1 in 5 patients on impeller, as opposed to 1 in 10 patients in the control arm. 5% had significant limb ischemia versus 1% in the other arm. There was more renal replacement therapy. There was numerically higher risk of stroke. So the number needed to harm was also relatively small as well. But these patients are critically ill, and the trial was able to show significant improvement in survival. Why was the trial positive? Well, an impeller is a much more effective mechanical support device than intra-aortic balloon pumping. And I think, although this is controversial, I think getting support done before PCI, it was done in approximately 50% in danger shock, rather than about 12% in intra-aortic balloon pump shock. I think that certainly has the potential to support a patient very well through the PCI procedure. And if we are to realize the potential benefits Impella support, then it will need to be available in every primary PCI centre in Scotland. So cardiogenic shock remains a very dangerous condition with a high mortality rate, but there are reasons to be cheerful. The Bristol approach demonstrates that the close collaboration between ICU and cardiology has the potential, through doing the simple things right, doing it right each time, being very clear about rapid escalation rather than sitting back and waiting for events to dictate escalation. If we do it earlier, we are likely to achieve survivors, whereas a later escalation would not. I think we're going to try very hard to develop Impella. We've done a couple of cases for severe complex PCI support, but it will be a very different matter for providing 24/7 service, and we will have to think very carefully about it. I think NICE are likely to approve following the successful trial, and given the current finances, I'm looking forward to writing a compelling business case. Okay, that's the end of the talk. Are there any questions? Nothing new in the chat. So, Euan, you've discussed the potential for a shock team in ITU, and I understand that that's been quite well received by your colleagues.
Yes, I think so. I think the concept of earlier discussions and having the ability to make decisions when there's not necessarily the time pressure of an acutely deteriorated patient in front of you is always beneficial. And I think we're probably recognising that more in intensive care more and more, that the earlier we're having these conversations and making decisions about patients and what we're going to do, the easier it is to enact them, and the better the patients do.
We've had balloon pumping for many years, but it is unusual for a balloon pump patient to be in ITU. I would say, it's not something that's happening every day. Impella will have much bigger vascular, much bigger tube in the femoral artery. There'll be a lot more bleeding from that. How do you think that will be received? How do you think we should be training people's expectations that they won't dread an Impella patient coming through? They'll think positively about it.
I think that's a good question. I think until we've dealt with it and seen it, we won't really know how people respond to it. Balloon pumps are relatively rare, but I think we do have at least some sort of confidence in managing them now. We've seen enough of them. We're used to reasonable sized lines, probably not as big as the balloon pump, the Impella lines being in. We'll just have to get used to
Yeah.
it.
My discussions with a colleague from Birmingham, and they've got a well-established Impella program, is that essentially, as the consultant cardiologist who's chosen and in place the Impella, effectively you have to just commit to being available to troubleshoot, because for a device that will potentially use up to 10 times a year, I would say, it will be difficult for most members of staff to gain a huge amount of experience with it. The console is becoming increasingly sophisticated, and actually managing that is a decreasing issue, and there'll be central management from the company that advice will be available. I think they're very keen that obviously that the UK develops these services, and will be keen to support. Anyone else? Well, quick interventions is what we want, quick talks. I'll bring the meeting to a close and invite you to next Thursday's meeting. And I think Professor Farden will still be absent on his prolonged holidays, but it will be presented at the usual time in the usual place. All the best, everybody. Thanks, Euan.